All right. Hello, everyone. I'm Aubrey Rhodes. I have the privilege of serving as the executive director for the Lung Cancer Research Foundation. And our middle name is Research. LCRF's primary focus is funding research. Our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. We also believe that the informed patient is empowered to make the most of the research. And so that's why it's really important to us that we bring this sort of programming to you today to really bridge the gap between the research and the patient. So today we're going to cover a wide range of topics on the impacts of receiving a lung cancer diagnosis at a young age. And at LCRF, it's really important to us that the patient voice is incorporated in everything we do, especially when it comes to research. And I am so pleased today that we have a few guest speakers who are going to be sharing with us their direct experience having lung cancer as a young individual. And we're so grateful they can be here with us. I will let Iz introduce them shortly. But before we get started, I just want to thank our generous sponsors for making today's program possible. I also want to remind everyone to stay on mute. The chat is open, so we encourage you to share your questions in the chat. We do try and stay away from personal questions about your own diagnosis. I will also share that the captions are enabled right now, both in English and Spanish. You do have the option to turn those off in your Zoom settings. And aside from that, it's now my pleasure to introduce our beloved Together Separately moderator, Dr. Isabel Preeshagul, who is an assistant attending on the Thoracic Oncology Service at Memorial Sloan Kettering Cancer Center. Take it away.
Thank you so much. That was so sweet of you to use that word. You are my beloved family too, all of you that are on here. And thank you for joining on this beautiful Wednesday. We are excited to be talking about this topic that has yet to be focused on with a spotlight in a Together Separately event. So I'm glad that we are finally able to shine a light on this area that really needs some attention. So I am joined by three incredible guests today. The first is Dr. Eric Singhi. He's an associate professor at MD Anderson, thoracic medical oncologist. And I'm joined by two incredible patients, Caroline Blanchard, and we also have Lauren Corcoran. And we will be hearing from all three of these incredible guests peppered throughout our talk with various topics. And I'm going to let Caroline and Lauren really introduce themselves when they get called on and share bits about their story. I think they can do a far better job than me trying to introduce them. And I would rather hear from them. So first, we're going to just start off with hearing a little bit from Dr. Singhi, Eric, about the work that he's doing in this space. He's really been a trailblazer here. And Eric, could you just tell us a little bit about what you're working on in regards to young lung cancer and why it's so important to you?
Yeah, thanks so much, Iz, for having me. Dr. Preeshagul, I know we're good friends, so I'll call you Iz. First of all, thanks to LCRF for just shining a spotlight on this very important topic. It's definitely under-recognized, it's underfunded. And unfortunately, we see a lot of patients with young onset lung cancer who have this delayed diagnosis. And so I'm sure Lauren and Caroline will highlight this as well too. And so there's definitely this growing effort, this unmet need to really shine the spotlight on increasing the diagnosis rates, making sure we understand the biology, sure that we really treat these patients appropriately. And so at MD Anderson right now, myself, as well as several multidisciplinary colleagues, including Dr. Mara Antonov, who's a thoracic surgeon that I worked very closely with, have a growing passion for taking care of these patients. Right now in the nation, about 10% of cases of lung cancer are defined as young onset lung cancer, which we define as patients who are 50 and younger. The average age is at 70 years, right? But we're seeing this rising incidence of patients who are younger being diagnosed, and we're trying to understand why. So what I'm doing right now is research focused on understanding why, research focused on understanding how we can really customize and tailor our care for these patients from a multidisciplinary angle. And then I'm also very focused on patient education and communication. And so a lot of the research that I do is focused on that and making sure patients feel empowered, engaged, and really on top of being involved and truly being a partner in their care.
I love that. I absolutely love those words. And I see you on Twitter. I see you on social media, just preaching about all those things, and I thank you for that. So you touched upon a couple really important things, and the first thing you talked about was challenging with initial diagnosis. And we see that a lot of times there's still this terrible stigma about patients with lung cancer, that they've had a heavy smoking history, maybe they're older, maybe they're male. So you have someone, as young as Caroline and Lauren that come into their primary care doctor's office, let's say with a cough that's just not going away. Lung cancer is the furthest thing from the primary care doctor's mind, right? So it's going to take them forever to want to order imaging or do anything, and they're going to try everything outside of that to try to fix this cough. So, Lauren, I'd love to hear a little bit about how you were diagnosed, and tell us your story a little bit.
Sure. Can you hear me okay?
Yeah.
Awesome. Hi, everyone. Thank you for having me. It's nice to virtually meet you all. I think young lung cancer is unusual. My story is more unusual in that there were not symptoms. So I actually stumbled upon my diagnosis. My daughter had just turned 1. I was 38 years old. My husband and I wanted to get back in shape after having my first baby. We were training for a half marathon. I tweaked my neck doing a kettlebell pull. We had just bought a new house and we couldn't get a primary care. And so I went to a chiropractor who sent me to her friend, and the primary care just said, hey, that stinks to like pick your baby up in the crib. If it doesn't go away, just get an x-ray. The x-ray did show eventually that I did have a disc inflammation from an injury that has healed itself. And next to that, up near the injury, was an unrelated advanced tumor. And I was diagnosed with stage 3B lung cancer, EGFR. It's now 3C. I found out they've changed the diagnosis criteria, but yeah, I was just, contextually extremely blessed to stumble upon it. I didn't have a cough. I didn't have pain. And obviously it was decently advanced at that point. So I was very, very blessed to find it.
Wow, definitely. I that is a blessing that you were able to find it that way. And I'm so glad that you are okay and you are here to tell your tale. I think we actually see incidental diagnoses a lot in patients young, just like you, and just like you, Caroline. Eric, what has been your experience? Who's the common patient that you would consider a young patient that comes into your office, and is there a sort of pattern about how these patients come in?
Yeah, so probably more than half of my clinic now is defined as young onset lung cancer. So the majority of my patients actually are coming from all over, which is just crazy to think about, right? How the face of lung cancer has truly changed. We used to picture this elderly male with a heavy smoking history who was in his 70s. That is not the case anymore. And I'm trying to spread the word about that. I go talk to primary care physicians. I go out to the community. Community outreach and engagement is huge to me to make sure people understand it. What I see, yes, are cases like Lauren's where they're going and they get incidental imaging. I've had patients, for example, who've gotten in a car accident and they found imaging through that way, right? That they had a lung mass. But what I see more than often, unfortunately, is advanced cases of diagnoses that are happening. So stage 4, they come in, they've unfortunately had multiple workups after some time, several months, thinking it was an infection, get rounds of antibiotics, get steroids, it's not getting better. Or really their symptoms have been dismissed. People think it's anxiety, people think it's asthma, you name it, they've been diagnosed with it, except the right diagnosis, except lung cancer. And it's really, really unfortunate.
Yeah, definitely. I think I am unfortunately seeing more of the latter, that patients are actually having symptoms. I had a patient when I first started that actually had back pain during labor. Oops, sorry about that. That had back pain during labor, and that was kind of poo-pooed. And then imaging in the postpartum, I guess, period of her life led to finding a spinal metastasis. So I think, that really sort of set my alarm off in regards to, wow, this is totally not so rare, maybe. And I appreciate your insight about that. But as you had mentioned, there really are delays in care because patients, just like you both are, and many on this call, are just sort of, being poo-pooed or being told that what they're experiencing is not something is not something serious. And oftentimes it's them advocating or asking for imaging or trying to like push the doctor a little bit more to get what they need to get the diagnosis. And that I have heard far too common. Caroline, could you tell us a little bit about your story? And I don't know if you had any delays, but if you did, could you share with us?
Yes. I apologize for any distractions or background noise. I have my 3 and 4-year-olds home unexpectedly right now. I hear someone crying in the background. But my story is a bit different. I was born with a genetic mutation. I have the EGFR T790M germline mutation. My grandmother is 80. She has stage 4 lung cancer. And my aunt died of lung cancer in her 40s. So it was recommended my grandmother get genetic tested. And then my mom found out she had the genetic mutation. She was later diagnosed with lung cancer. And then I got tested, and it was time for me to get just a baseline CT, and insurance wasn't paying for it because there's no guidelines on lung cancer screening. And I was 31 years old at the time and had no risk factors. So went back and forth with insurance, and they ended up not paying for it. So I actually had to pay cash price. And then on that first CAT scan, I had several nodules throughout both my lungs. Thankfully, all stage 1s, but it was not easy to get that first CAT scan or to, to start.
Definitely not. And I think you actually touch upon something that I was hoping to talk about later today about germline alterations and how there's this also misnomer that, breast cancer and colon cancer have, family history and lineage, but don't worry about lung cancer. And that is so not the case, right? There's germline alterations, as you so perfectly explained, throughout your family. And I'm glad that you got checked, and I'm so glad that you pushed, and I'm so sorry you had to pay for that scan. That literally it's sickening that you had to do that. And I am hoping and praying that we will be able to find a way to get screening guidelines and workflows organized for patients just like you with family histories, that you shouldn't have to go through that. It should not be that way. But as you know, until we can prove that the excessive exposure to radiation prolongs your life, and changes outcomes, it may be difficult to move the needle very, very quickly. But I am not feeling negative that that's not going to happen. So in regards to other opinions, because I think these cases can be very unique, and I know there tends to be times where doctors may sort of say, oh, don't worry about it. Eric, are you ever finding that these people that come to you are, you might be their third or fourth doctor that they've seen?
Yeah, I think one of the incredible things that I'm starting to see now is patients are empowering themselves. They're becoming really educated, and they want to talk about the treatment that they're on and if there are other options, which I'm a very big supporter of. I think really advocating for yourself, advocating for your health, and if you're with an oncologist and you're worried or you're nervous about seeking out a second opinion, please don't feel that way. That's really a check for the oncologist. If they have a problem with it, that's on them. That is not on you. That's not on your family. You're the one with the lived experience. You're the one with the diagnosis of lung cancer. And if you want to see what the options are that are out there, whether it's clinical trials, whether it's just reassurance about the standard of care treatment that you're on, or if you want to talk about options like local consolidative therapy, things like surgery or radiation, when those things are not conventionally given for advanced disease or stage 4 disease, please don't hesitate to ask. That's several types of consults. I see that weekly, all the time.
Yeah, I echo that. There's so many times where I see a patient and they'll say, oh, don't tell my doctor that I'm here. Don't send my note, the note, or I'm worried, and I totally agree with Eric. Like, if they're worried, then that's not a good thing, right? That doctor should want you to go where it feels like it's a good fit. And sometimes you need to date a lot of different people before you figure out who you're going to marry, right? So you need to see a lot of different doctors to figure out when it feels like a good fit. And no one should be upset about that. It's about you, and it's about your journey. So I totally agree with that, and about the patient empowerment. Did either of you seek, medical care from various doctors, or what was your, Lauren, I see you nodding your head.
Yeah. So I think two things. One, just on the advocacy. While my X-ray did show something, they actually said it's a small opacity, check back in 6 to 12 months. And so they didn't identify it as lung cancer right away. And something sparked in my head where I was like, that just feels wrong. I don't know if it's because I was a new mom and I was like hyper anxious, but it was the double click into it where we then got a second, like I literally turned my body for a different X-ray, and that's how they found it. So like very much advocate for yourself. Like I could have just taken that with a grain of salt, gone about having a newborn and never gotten that second X-ray. And it likely would have been a very different situation for me now. So something feels wrong to you, just push on it is one. And two, on the second opinion, I was extremely nervous. I live outside of New York City, but I was at a local hospital here, but had access to MSK and to Dana-Farber. And I didn't want to hurt anybody's feelings, but was very much supported by my local team. They were on the phone with each other. Their tumor board spoke to each other. Like it was very, very collaborative. And I was super surprised. Like I kind of thought it was like this team or this team, but they were calling each other. They worked with each other regularly. Like the oncologist I was at MSK knew my local one. And I think they still talk during my scans and stuff. So I had a very surprising, but also wonderful experience where like they encouraged me and like wanted to chat with each other about it and wanted to stay in the loop, even when I made my choice on who I was going with. And have always been really, really supported that way.
That's amazing. I'm so happy to hear that.
I have like the best team, but but in general, they were like, this is very normal. You should always get as many opinions as possible. But also I love them.
Yes. But I'm glad that you like your team, but I'm also glad that everyone was so receptive. I don't think that's always the case. So I think you may be in the minority, even though you should be in the majority. But that's awesome. So I do want to talk just briefly about these reproductive concerns. I know that you're both women in this space, but there are men that also get diagnosed with lung cancer at a young age. And while we have fertility concerns about egg preservation and ovarians and hormone levels and all these different things, they also are thinking about what about my sperm, what about my libido, what about my just overall sexuality? How are these medications going to change my body? What is it going to look like? Am I still going to be attractive? Like all of these different things. So I think, Eric, how do you counsel your male patients that you're seeing in this space?
Yeah, that's a really good question. So I'm thinking of a few male patients that I have younger than 40, and many of these patients came to me with a brand new diagnosis. And it's almost like you're in this fight or flight mode immediately when you get the big C diagnosis, and then your oncologist comes and talks to you about support and sexual health and fertility. And it's almost like they just give me a blank stare. And I'm like, no, but we really do need to focus on this too, because my goal is to hopefully make this a marathon, not make this a sprint for you, right? I want to focus on, my patients hear this from me all the time, mind, body, soul connection. Like we're always so focused on the body, but just as much as that, your mental health from the mind standpoint, your soul matters so much. I'm also a big believer that positivity attracts positive outcomes. And so we talk about a lot of this up front. And so it's almost like we're overloading them from the beginning, but they will hear from me about referrals to our mental health program. They'll hear from me talking about referrals to our reproductive counselors, our oncofertility program. Those are huge things. And so we talk about all of that. We lay out a plan very upfront, and we talk about the importance of things like sperm banking if patients are interested, for example, in making sure that they have family planning accounted for at the time of their diagnosis.
Definitely. And I think that we have a lot of resources being at MSK, myself, and also being at MD Anderson, that our patients are well supported. But there are many patients, on this call and outside of this call that get diagnosed at community hospitals where there may not be as much support. So they really lean on maybe their friends or family. But that's why I think we really need to make sure that they know they can come to LCRF for these resources. They can come to us to hear about these talks, and there's links and there's educational materials, and I know Courtney can probably send out some stuff when we're done with this. But I think that we need to make sure that everybody feels like well connected and well supported. And I think I think that that is something that is lacking in this space for sure. So we're going to be talking a great big deal about, women and lung cancer and fertility on May 14th with Dr. Flores. That's a plug for that. So would love for all of you guys to register. There's a link down below. So stay tuned for that. She's a trailblazer in this space as well. So I'm going to kind of covet a lot of that information so that we have a lot of really juicy things to talk about when I speak with her on May 14th. But I want to go on a little bit more to what Eric is working on with Mara Antonoff at MD Anderson, that which he had kind of touched upon, which is sort of local consolidative therapy and multidisciplinary approach. Because when you have somebody, unfortunately, that is maybe older, maybe more frail, it doesn't have as much reserve. Obviously, we are going for a marathon. We are not going for a sprint. But the way that we shape their treatment plan tends to be a little bit different. And we worry about putting them through maybe aggressive surgery or various local therapy options that are, maybe not completely standard of care as of yet for patients with stage 4 disease, but we're really exploring this space. But for young patients with lung cancer that are more fit, we tend to be a little bit more appropriately aggressive. So, Eric, could you tell us a little bit about this program with Mara Antonoff, please?
Yeah, of course. So Dr. Antonoff and myself are currently, with many of our colleagues here at MD Anderson, very focused on trying to help and advance the care for patients with young onset lung cancer. Our chair, John Haymack, is very supportive of this as well, which I really appreciate. Our goal is to open a multidisciplinary center, a clinic within our institution itself that's dedicated to young patients with lung cancer. Would be one of the first in the nation and internationally, really dedicated to making sure this is a concerted effort. Is you highlighted very nicely that we need to have a lot of different players involved from the healthcare standpoint to really make a difference and to make an impact for our young patients with lung cancer. For all types of cancer, just in general, cancer care really takes a village, but I strongly, strongly believe it for young onset lung cancer for several reasons. One, many of these patients are overall quite healthy, with the exception of lung cancer. They have not really been plugged in very much to the healthcare system. They don't have a lot of other comorbidities or other health problems, right? And so they have a very high reserve and maybe even a tolerance to tolerate more things that are aggressive, quote unquote, aggressive, right? The other thing too is that many of these patients were not studied in the clinical trials. All the big trials that we have, the average age of patients on many of those trials was 60, 70, right? Not the younger patients, not the 21-year-old that I saw 2 months ago or the 23-year-old, right? So we don't have good studies right now that really focus in on this patient population. And so a big goal of this center is not only to connect the patients from upfront when they come and meet us at the door to all the different multidisciplinary colleagues, sexual health, oncofertility, psychiatry, supportive care, integrative medicine, but it's to also start gathering data to say, hey, we're starting to get large numbers of these patients. What are their outcomes? What are the outcomes specifically if we're more aggressive about their treatment? What about really making sure that they are matched to a clinical trial that may give them the best potential hope, right? So being very thoughtful up front is what we're focused on. And then the more specific question you asked about was something called local consolidative therapy, or we call it LCT. Myself and Dr. Antonoff get a lot of these consults. And so what LCT means is a patient has advanced stage disease, let's say stage 4 disease, and you start off with some type of systemic treatment. A systemic treatment is either for many patients an oral drug like osimertinib or alectinib based on your mutation, or it can be chemotherapy or immunotherapy that goes through the vein. But you start off with that treatment, you get your first restaging scan a few months later, and then you look with your oncologist. And let's say you're having a really good response, right? You're starting to see shrinkage of your disease. You're not seeing new disease that's growing. Then you ask the question, what else can we do to boost the control of the disease that I had, right? What else can we do besides the drugs that I'm on? And that's what we call LCT, whether it's with radiation or whether it's with surgery. What else can we do to boost and help clean up the rest of the disease that's there and hopefully give you more time to stay on the drug that you're on, right? Because we want to make this a marathon. That's our goal.
Yeah, I think that is a question that comes up all the time in our tumor boards, right? Like I've been on osimertinib or I've been on this chemo for X amount of time, and I just have this residual left upper lobe thing that looks like a scar and nothing else. Like, can I come off treatment? can we just cut this thing out, doc? Like, could you radiate it? What can we do? And I think there really is no data on this, right? And we think about if we are going for a marathon, just to play the devil's advocate, not a sprint, and we know this patient has stage 4 disease and they're committing themselves to lifelong treatment as long as they feel like it's tolerable to them and we feel like it's benefiting them. If you're going to take out part of their lung or scar part of their lung, right? When maybe they have no symptoms from it, it's just something we see on the scan, they're going to need that lung function at one point, right? Or they're going to, like, do you really want to risk that toxicity? So that's something that we also have to take into consideration, right?
Yeah, these are very nuanced cases, and so we really take a lot of time, myself and Dr. Antonoff are probably on the phone every other day just talking in depth about cases, and we bring them to what we call our tumor boards, our multidisciplinary conferences, where we have almost 40 different doctors that are there, from radiation, from surgery, from medical oncology, pathologist, radiology, and everyone's going into the details of the case and then having that open discussion. So every case is different. Every case of even stage 4 disease is different, right? And so if you hear something from one friend, if they've been turned away for LCT, LCT, it doesn't mean that's the same for your case, right? And so make sure you take the time to, and if you're interested, go seek out that opinion, go ask that question. I think it's really important. And then the other thing I'll say too, real quick, is most of the data that we have so far is not really in young patients with lung cancer. It's in older patients. It's also in different types of systemic therapy that many patients aren't getting. So immunotherapy, chemotherapy. Newsflash, our treatments have actually gotten a lot better with regards to targeted therapy, which many young patients qualify for. And so now the question has become, if our therapies have gotten better, our systemic therapies, does that also mean we now have an opportunity to really pull in LCT and all these other multidisciplinary treatments?
I agree. It's very nuanced. And Caroline, you had just begun to share a little bit about your story, that you have these small bilateral pulmonary nodules, and you said thankfully they're all stage 1s. Could you tell us a little bit about what happened with your diagnosis? Would love to hear a little bit about that.
Yeah, so my mom she was diagnosed at age 50 with stage 1 multifocal disease. So just from following her cancer experience, I was very well informed, and I really just kind of followed behind her footsteps. My mom lives in New Jersey, and she actually had surgery at Sloan Kettering with Dr. Park, and she actually saw you, Dr. Preeshagul, and we've talked on the phone before briefly. And so I really knew what to expect, and but sorry, I'm distracted with the crying in the background. What was
Do you
the
want to
question?
get your baby? I can come back to you.
It's okay.
I feel you. I have a screaming 1-year-old if you're hearing her.
I don't.
Okay, good. The question was just a little bit about your story, because you said that you knew that you had stage 1s. So I'm just wondering, did you have both lungs sampled? Did you have next gen testing done to tell us that they're all unrelated?
Yeah. So I had a wedge resection. So first I had my first CAT scan, and then the plan was to get a repeat CAT scan in 3 months to see if anything was growing. My largest nodule at the time was 23 millimeters, but it was kind of more ground glass, like wasn't really a solid nodule, but there were some changes at that 3-month scan. So it was decided to go ahead and just do a wedge to resect it. And then at that time, there was a few more nodules on the periphery that were also resected. And that was 2 years ago now. So really since then, the rest of my nodules have been stable. I got CAT scanned every 6 months for 3 times, and now I'm spacing out to 9 months. Reason being because, we're all young here. We also need to be mindful of radiation exposure.
Definitely. And I appreciate you diving into that. And of course, I know your mom. I just didn't know if you were going to feel comfortable saying anything. But yeah, so I think that just kind of highlights how patients are treated a little bit differently, right? If you were to have been, much older, or maybe not at an academic center, someone might have looked at your scan and seen bilateral pulmonary nodules and thought, oh boy, that looks like stage 4, right? This patient has an EGFR T790M alteration. We're going to offer her osimertinib, and you would have been on it for life. So I think it's important to be aggressive, but that just kind of makes me feel comfortable and confident that we are being a little bit more aggressive for our younger population, and appropriately so, because you're not on systemic therapy and you shouldn't be. And that's a really good thing. And I'm happy to hear that.
I think you got muted, Is.
Thanks. As you had highlighted, you have a T790M germline alteration. Eric, could you talk to us a little bit about somatic versus germline, and how you handle patients that come to you with germline alterations?
Yeah, this is a really good question. So germline mutations, this EGFR mutation, is not very common in lung cancer. The number that I can quote is about 1 to 2% of cases, which is pretty rare, but it happens. And surprisingly, I've seen several patients that have had it. And so I don't think we can necessarily exclude that patients with lung cancer don't have a germline cause of their disease. And so I always obtain a family history. We talk about if, any family members have had lung cancer. And if patients are interested in getting what we call germline genetic testing, I absolutely refer them to a genetic counselor at my institution. But one of the most common questions I get asked is when we go through all this molecular testing, this mutation testing, this biomarker testing, I'm throwing out a lot of synonyms because everyone calls it something different. And we just need to make sure that everyone understands that there's a lot of different names for it, but it's so, so important, especially for young onset lung cancer, but any patient with non-small cell lung cancer, very important. But this difference between somatic mutations and then germline mutations. So somatic mutations, or sometimes we call them acquired mutations, these are changes in the DNA of the tumor cells itself. So for some reason, over your lifetime, the tumor cells that are in the lung, they developed this change in their DNA. And that's what we're testing for a lot of times, for the most part, when we talk about biomarker testing in lung cancer, is looking specifically at those mutation changes in the lung cancer cells themselves, meaning that this mutation is not in your other cells in your body. And then there's germline testing, where these are mutations, changes in the DNA that you were born with. And so in Caroline's case, actually that EGFR T790M was not just restricted to the cells in that lung cancer, but actually in all of the cells in the body. And so one of the most common questions I get asked is when a patient, for example, of mine may have an ALK fusion or a KRAS mutation, all these other mutations, is my family at risk? And am I worried that I'm going to pass this down? My typical answer is no, because these are somatic mutations. These are mutations that are restricted to the lung cancer cells themselves. But again, if patients are worried, they still want to assess their risk from their family standpoint. We're still learning as a community as well, too, all the different causes of lung cancer. Seeing a genetic counselor is something I absolutely offer to my patients.
I'm very happy to hear that. Lauren, could you tell us a little bit about your experience? Were you offered next generation sequencing testing and a meeting with any genetic counselors at all?
Yeah, this is all very relevant to my current state. So I'm actually learning and appreciate what you just walked through, Eric. They did biomarker testing after the or I guess during the bronchoscopy, and identified EGFR 19. Sorry.
Okay.
Just keep going.
Keep going.
So it's EGFR 19, which, as background, like nobody in my family's ever had cancer. It sounded like it was like the most foreign language. Like everything was like, I was just like trying to keep up Googling, had never heard of it, didn't know the first thing about lung cancer, no less cancer. Had different opinions and recommendations in the 3 hospitals that I spoke to. And so it was kind of a crazy experience for my husband and I to choose the one that we thought was the best, with absolutely no background in it. But they all had different flavors of this. It was just different order of things. So my story is, we did chemo radiation as first line of defense to try to shrink things. It was a primary tumor with lymph node expansion in my mediastinal, and then 1 lymph node on my right lung, which is what made it stage 3B or C. once it got, they were happy with the results, or happy enough. And so they did perform a upper left lobectomy. So they removed the top left lobe of my lung. And upon seeing the findings of the remaining cancer, it was sort of right on the fence. They put me on a multi-year Tagrisso, which I'm still on every day. So we kind of ran the whole gamut of all of it. I did not do germline testing at the time. This was about 2 years ago. I think they threw everything else at me because I just would I was actually just taking this off my wall. I would just bring this picture to every appointment and be like, I'm not going anywhere. So like I would put on a full face of makeup and heels to go to all my doctor's appointments. And I was like, I'm not going anywhere. Throw everything that you can at me. Let's, like, it was a job interview or something. I wanted them to know that I was strong. But we were trying for a second child at the time because we were, in our late 30s. And that obviously put a pause on things. So I have just started working with Dr. Flores, actually, alongside my doctor team around the potential of, I know we're not talking about that right now, but as part of the analysis on whether we should move forward with that, surrogacy versus naturally, is I'm going for germline testing consult next week. So I just learned my pregame for it, which is awesome. And so that's my story, if I answered your question correctly.
You answered it above and beyond. That was perfect. And I am glad to hear the course that you had, and I'm sorry that you had to go through any of that, but I think it was appropriately aggressive, and it sounds like you are on the right track right now.
Oh yeah, sorry. And I am just came up on 1.5 years, no evidence since my lobectomy. So that's going back to the beginning when I say I'm blessed to have run into this diagnosis when I did. We are hoping and wishing and praying and knocking on like all the wood that things continue the way that they have been.
That's great. And I appreciate you sharing that. And I wish you luck at your germline alteration testing consults coming up. Yeah.
Might be a little more nervous about that, but
okay. So Eric, you had mentioned the importance of mind, body, soul, which I try to preach in my clinic as well. And I just, we have a lot of resources, but it never seems like enough. So obviously there's so much that comes with a cancer diagnosis, emotionally, socially, physically, you name it. So what resources are you typically offering your patients or advising outside of, therapy?
Yeah, first of all, I won't discount therapy. I think it's really, really important. I did an interview maybe a couple months ago with a colleague of mine at my institution who's a psychiatrist here, and we talked all about mental health and how we actually need to normalize this, especially for patients with cancer. I really like the analogy that she gave where we go and get our routine dental checks. Why don't we get routine mental checks, right? Like, honestly, why is there so much stigma around this? There really should not be. And so, yeah, my patients probably get sick of me saying mind, body, soul, but it's so, so important because we're always so focused in the science before we bring it to clinic. What are the Kaplan-Meier curves showing? What are the statistics showing? What are the hazard ratios showing? Okay, great. But what does that actually mean about the patient that's sitting right in front of you, that's sitting right across the room, right? Like, that's really who we should be focusing on. And they're just not this person where we're looking at the scans and we're so focused on the scans. There's a story behind the scans, right? They've got to get home to their families. They have a lot of other responsibilities to juggle, and quality of life matters just as much. And honestly, as a community, we're still learning about patient-reported outcomes, quality of life outcomes, how to study these, how to really make sure that we're thinking about all of this. Because let's face it, in the lung cancer world, survivorship is a new term. I'm actually putting together a grant right now about survivorship for young onset lung cancer. And it's like this novel term because, one, we don't even know much yet about young onset lung cancer. And two, hearing this word survivorship for these patients is something new. So we almost have to think 20 steps ahead, right, for these patients. What are we going to do in terms of how we sequence treatments? What's the best treatment to start them off with? Yes, to have more time with their families, but also to make sure we preserve their quality of life. So yeah, that's just my general thoughts and my general spiel from the start.
I love that, mental checks and dental checks. That's so cute and so appropriate. And oftentimes I will offer meeting with our psychiatry team and our social work team. And patients sometimes say, oh, I don't think I'm there yet, or I don't really think I need it. And I used to, in full transparency, I used to be like, oh, okay, I didn't want to push it on them. But then I actually saw one of my colleagues told me to, or suggested that I say, what are your hesitations or what are your reservations? And if someone, oftentimes that opens up a lot more, right? Maybe their family member had a bad experience, or they had a bad experience, or they're worried about someone looking in their chart and seeing X, Y, and Z and labeling them or whatever, or maybe they're thinking that depression or anxiety looks like this, and it only looks like this, and it could never look like, what they're experiencing, like change in sleep or change in appetite or any of the less common side effects of, not side effects, less common symptoms of depression or anxiety, what they may look like. So I appreciate that. I think definitely, in addition to those referrals, I want to make sure that we have, lots of good support groups. I think there's a support group, Terminal But Living, that we know about. There's LCRF support groups. There's Longevity has support groups. And if you're on this line and you have not reached out to your oncologist about any of these options, I encourage you to. And if there's none where you're getting your care, go to lcrf.org. There's so many resources on there. There's a social work that there's a 24-hour hotline as well. There's resources there for you, and you should not feel unsupported. So that's so important. I saw that a question came up in the chat, and I don't want to get ahead moving on to another topic. Viviana from Romania here. Wow. Is local consolidative therapy an option for second line TKI? Eric, I'll let you go ahead.
Yeah, it's a good question. And it's nice to see that we have attendance from Romania. Wow. It's a good question. Every case is different, though, is what I'll say. And so when we're thinking about if a patient is having disease that's growing on a first line TKI on that first treatment, I will say you really want to understand why that's happening. And so if there's an opportunity to go for a biopsy of that new site of disease that's growing, so then your doctor can repeat testing, better understand if there's a new mechanism of resistance that's teaching the cancer to grow despite the treatment that was working, that's really, really important. Knowledge is huge. It's power in this case. So advocate for yourself first to make sure you understand why. And then the second thing is, where is it growing? Where is it progressing? Is it in just one spot? Is it multiple spots, right? LCT is used differently in those terms. So if a patient's responding really well to their first treatment, then you have an opportunity to try things like surgery or radiation to clean up spots. But then we call it something different. We still use local therapies if a patient's disease is growing, but we do it in a different way, so much to try and prevent some of the disease that's breaking through the disease that's being treated with one drug. But you can do radiation to those spots. You can also do surgery. Those things can be considered, but every case is different based on, is there a reason that we understand why the cancer is growing on your first treatment? And then second, where is it growing? So talk with your team about both of those things.
Yeah, I agree, but I also think what you're getting at is that there's no time limit to when someone can go for local consolidative therapy, right? You could get it after your first treatment or after your fourth treatment. It all depends upon, when you feel ready and your team feels like it's a good move for you at that time. But the exact timing of when to offer local consolidative therapy, I think, is not well ironed out at all, right? Do you want someone that has stable scans for 3 months, 6 months, 5 years? No one really knows, right? So I think the jury is not out yet. Okay, so in regards to clinical trials, which you had mentioned, which are so important, historically speaking, I think there's been a big misnomer about trials and thinking that they are sort of last-ditch efforts, or this innate feeling of, oh no, my doctor's talking to me about a trial now, things must be going in the wrong direction, or my cancer must be really bad. And that's totally not the mindset that we're having whenever we offer a clinical trial to our patients, right? So how do you often talk to your patients about clinical trials? And then I would love to hear from Lauren and Caroline about if they've had any experience talking with any practitioners about this.
Yeah, so you're absolutely right, they've done surveys. The NCI, National Cancer Institute, the NIH have done surveys, and they've asked patients, have you heard about clinical trials? If so, who's the one that's explaining it? Or if you haven't heard, who did you wish you'd heard it from? And what we saw was that a majority of patients had not even heard about clinical trials. They were not offered a clinical trial. And the person they were going to go look for and talk to about options is their primary oncology team, right? So it's really just this unmet need in terms of communication and education. I think we need to be doing a better job in terms of just being providers ourselves to offer that, to open the dialogue, to use open-ended questions to understand patients' preferences and then introduce clinical trials. So yes, we are constantly looking at our institution from the first time I meet a patient. Do they qualify for a clinical trial? Do they not? Really, all of the drugs, and I tell my patients this, all of the treatments that we have that are approved by the FDA are because of clinical trials. It's because of patients who stepped up several years ago very courageously and selflessly to say, there's maybe this treatment that offers more hope, that offers maybe more time with my loved ones. And yes, it could help me, but it could also help the future of science and help other people. And so that's the way I explain it. We have a clinical trial team that's screening our patients in advance. And then I also really lean into patient education. And so I've worked to publish a few different things as well explaining in patient-friendly language, what are clinical trials? What are the different phases? What are the top questions to ask your team about clinical trials? Education is everything about this.
Yes, so well said. And I couldn't agree with everything that you just said. And I think that there's actually a problem if you are seeing an oncologist and they've never offered you a trial, because that could mean one of many things. One, there aren't clinical trials that they're tapped into or that they have access to, which makes me concerned that perhaps you're not getting, hearing about all the possible options. Two, it could be that they just don't have time, or they're uncertain about what's available. Or three, it could be that they are they're just not believing in the science that's going on right now. So you should always ask your oncologist, hey, are there any clinical trials that are available for me? And if there aren't any here, where else could I go? What website can I go to? Can you refer me somewhere else? I can't tell you how many times I have a group chat on my phone right now of all the docs in the tri-state area that I trust. And I also ask Eric all the time too, hey, do you have any studies for a patient with X? Do you have any studies for this? Anybody, have any slots for anybody here? And that chat is just forever ongoing and so helpful, because we're all here to help patients. So if you're on this call and you have not been offered a clinical trial, or you have not even had a discussion about one with your doctor, I would suggest you just bring it up. And they may say, listen, you're doing great on the regimen that you're on right now. And then your response could be, great, but if for some reason something changes, I just want to know about what my options are. So, just because there's already an FDA approved agent for you does not mean that a clinical trial is wrong for you. And I think that's a huge misnomer, right? Oh, I have an EGFR alteration. I should be put on OC. That doesn't necessarily mean that's always right? There's lots of different options. So before I keep going, I would love to hear from Lauren and Caroline about your experiences here. Let's start with you, Caroline.
So I personally don't have any experience with clinical trials. Just I really haven't needed that much treatment. But professionally, I am an oncology nurse practitioner in urology. So I do understand the importance of clinical trials, and kind of going back to what Dr. Singhi was saying earlier, the importance of second opinions, really going to a cancer center of excellence. They can really open up the doors to clinical trials, which can really affect you and help you.
Thank you. And how about you, Lauren?
Yeah, so I have gone pretty much the traditional route. I have not been a candidate for clinical trial, but being pretty involved in the young lung cancer community, a number of my, we'll call it peers, that we would never want to be peers, but now good friends, right? That are stage 4, that's bodies build resistance, right? Are always looking for the next thing. And I know that they've had really great successes in like staying abreast of the different clinical trials that are coming out, and see a lot of hope in that space. So would definitely encourage everybody to look into those, because they're getting great results from it.
Definitely. And I know that you both are fortunate to have more earlier stage disease. Um, but there are clinical trials, just to highlight, that are available for patients with, stage 1 disease all the way to stage 4. So just because you have an earlier stage disease doesn't mean that you would not be eligible for anything. So in the interest of time, we have about 10 minutes left. I just wanted to open up the chat to see if anyone had any pressing questions. Otherwise, I really would love to hear, last words from our incredible, selfless guest speakers today. And feel free to put something in the chat or come off mute if it's easier.
Well, as I'm the furthest away from, I would like to thank you, everybody, for having these talks. This is the second talk that I'm in. I'm not sure if the first one was hosted by a medical professional, or anyway, I will move to my question because I wasn't sure about one thing. I have two medical teams, one local and one in Europe, outside, in Western Europe, and at the Anderson, actually. And I was asking if on lorlatinib for ALK mutation is a psychiatric medication approved or encouraged by the oncologists, or is just a trial and error thing until things work out? Because I know there is a dosage reduction possibility, and I don't know if there is a desire to keep the maximum dosage, or even with treatment, or even lower the dosage and don't have the treatment, the psychiatrical treatment anymore. I think I was clear enough. If not, please tell me.
I think you were very clear, and I think what you're getting at is that unfortunately patients that have stage 4 lung cancer with an ALK fusion gene driving their lung cancer, while we do have many treatment options, one of the treatment options that you are highlighting is known as lorlatinib, and this is a pill that is taken to kind of target any of those genes with that abnormal ALK fusion. And lorlatinib has a very well-known side effect that can happen, and it can result in hallucinations and depression and anxiety and mood disturbance, and it can be quite significant. And anybody with an underlying mood disorder at baseline really needs to be followed very, very closely. But even those without an underlying mood disorder, it's still recommended that you see these patients initially, at least while they're starting, very frequently to monitor for any of these side effects that could develop. Eric, could you talk a little bit about your experience here?
Yeah, this is a great question because I think a lot of oncologists in the first line setting for a new patient with ALK positive non-small cell lung cancer, historically, we've been hesitant as a community for reasons like this, because this drug can cause some of these neurological side effects, mood disturbances, speech problems, sleep issues, you name it, there's a whole spectrum of potential side effects. But it's a conversation we need to have with our patients because there has been some updated data just as of ASCO, our big cancer conference last year, where we had updates, we had long-term updates about how patients are doing on the drug lorlatinib from the start, from when they're newly diagnosed with lung cancer. And it's really impressive in terms of how long patients can stay on that drug without their disease growing, without their disease causing problems. So that means we got to manage this really well. And so one of the accompanying pieces of data that we got from that presentation was that if you dose reduce the drug within the first 16 weeks of starting treatment, you do not compromise efficacy. And so my practice has actually been to start at a little bit of a lower dose of lorlatinib. It seems to be better managed, including the side effects. So I don't shy away from lowering the dose. But again, every case is different. So I would definitely discuss this with your team. And then the other thing I do is I pull in family members. I say, hey, listen, this drug can cause some really strange range of neurological side effects. So you guys know your family member the best, right? So if you start to notice things that are off, advocate for them, let your oncology team know, and then don't be afraid to alert us and to alert other multidisciplinary, I think key players who may help.
Thank you.
Yes.
Thank you very much.
Family is key. I agree. We have one other clinical question, and then I want to have time to hear from closing remarks from our colleagues about chest tightness after lobectomy. I'm not a surgeon, but I definitely think, post-op recovery varies per every patient, and it's normal to have some numbness and some fullness and some discomfort there. Sometimes it lasts for months after, and sometimes it's permanent and there's a new normal. So I think everyone's experience is different, but you should always seek medical care with your own provider if you're having chest tightness and it's not going away. Chest pain, you never know what the etiology or the cause of that is. So if it's persistent, you need to get it checked out. Okay, so let's hear closing remarks from Lauren and from Carolyn and from Eric. Anything you want to leave, lasting remarks you want to leave our amazing crew here? Should we start with Lauren?
Sure. It's a little soapboxy, but I think, for those of you on the phone, whether you're a patient or you're a caregiver, I think going back to Eric's point around, or sorry, Dr. Singhi's point around mental health, I can only speak for my experience, but again, have gotten very close with a lot of people in this fight. And I think I have felt the low days where I couldn't get out of bed and I looked at my baby and didn't know if I was going to make her second birthday, and we had no idea what my outlook and prognosis was going to look like. I've felt the low, like very extremely. But I still hop on a plane anytime I can and fly all over the world with my family. And we did date nights through chemotherapy and tried to maintain some sense of normalcy, because I think, one, the numbers, lung or other, are just getting so that I do think normalizing cancer and showing that yeah, there's horrible times, but you can have very normal and long lives. I didn't know any of that, right? So when I was diagnosed, it felt like just a death sentence, right? I think trying to stay normal and stay active and enjoy the life that you have, even if it's not quite the same as you pictured, it was really, really important for me to still do the normal things. And people thought I was crazy. So people will react differently, but we traveled the whole time through treatment. I didn't even tell my job, I think, until I was done with chemo radiation. I just made it work, and I was nuts, but I needed that. I needed that normalcy and that normal part of my life to be able to fight through it and think there was going to be that other side. So feel the feelings, get the support, but try your hardest to fight against the very easy way of just feeling like you're going to give up. It's so easy to go there. And I think trying to keep some old sense of yourself, whatever it is that you love, keep that active as much as you can. And I do think trying to live for the day that you have is really, really important, at least for me to have gotten through it. That's it. And cheers and keep fighting.
I would like to thank the Lung Cancer Research Foundation and Drs. Preeshagul and Singhi for bringing us all together and really starting to bring recognition to young people with lung cancer that it exists. I think we can all relate that when we tell someone we have lung cancer, it still frustrates me when people are shocked. And I'm just wanting to make that known too, that young people can have lung cancer. And I really appreciate all the recognition. And it's exciting to hear, Dr. Singh, what you're working on at MD Anderson, trying to develop the program for people with lung cancer who are young.
Yeah, it's tough to follow Lauren and Caroline. Those are amazing sort of departing words here. First of all, yeah, thank you to LCRF. Thank you for this community. I think the community is just so important. So is the support. I love interacting with all of the groups. So that's the first thing, is lean into this community, not just to get information, but to really get that support. I think it's everything. The second thing I'll say is advocate for yourself. Young onset lung cancer is something that's very different than this traditional lung cancer. And so that means there may be more opportunities to be aggressive, to think about clinical trials, to think a little bit outside of the box in terms of how we're treating and managing your care. every case is different. So do not be afraid to reach out for that second opinion, that consultation to get your questions answered.
Thank you. All right, so I think for now we will close our chat out, and I will be thinking of all of you, and I thank you so much for joining, and thanks to Lauren, Caroline, and Eric for sharing their stories and their knowledge. Thank you, guys.